All right, we'd like to thank everybody for joining us today. I have with me Dr. Jack Lewis. This is a special event because this is actually our 1 year anniversary of the webinars that Jack did our first webinar and has come back to give us yet another successful webinar. So Jack, great work. Um,
Thanks, Eric.
you're absolutely welcome. So if you're not familiar with Jack, Jack was our inaugural fellow of the fellowship program. He is now an attending at both Memorial Hospital and does some time here at Maine Medical Center, and has some information on medical handoffs. So Jack, I believe the floor is yours.
Cool. Thanks, Eric. Hey, everyone. My name's Jack. I try to start every talk saying I identify as a paramedic. Maybe I should find a new line. Excited to be talking to you guys. We're going to talk about medical handoff, and I'm going to do the hardest part of the day, which is sharing my screen and figuring out how to make sure that you can see everything. So, handing off patients is kind of tricky. Um, it's one of those things. Eric did it. It did the thing, didn't it? Um, like I said, this is the worst
Yes,
part
it
of
did
it.
the thing.
All right. So handoffs are kind of tricky. We're going to cover um, kind of some background information a little bit. It's almost historical. Like, how do we use language in medicine? We're going to talk about what the problem is. Why do we care about this at all? Some tools to work on that, and then some thoughts about best practices. How do we do this consistently well? So, I was an English major. I can't help but get a little bit excited about language. And the first thing I wanted to talk to you about is this idea of medical syntax. So, how does the world of medicine communicate with each other? Because we really have our own language. I don't know, I remember a friend went to PA school, and one of the classes that she had to take was actually just a medical language class. And included in that language is kind of a certain syntax. So syntax is the way that we arrange words and phrases, and it is particular to a given language. So when I was in college, I studied German, and German syntax is very different than English syntax. And in fact, in German, you can move words around in a sentence kind of willy-nilly, and it doesn't matter that much because the way that the word is created defines its meaning and its role in that understanding. English is a little bit different. And in medicine, it's a little bit different. We really rely on the structure of what we're hearing to understand better. So the way that we present information and the way that we structure that information during the presentation really contributes to how well we understand or don't understand the things that we're hearing. So in medicine, that structure is kind of traditionally SOAP. So I'm sure that you've all heard of this, but SOAP stands for Subjective, Objective, Assessment, and Plan. So basically, what have we learned from other people? What have we found out for ourselves? What is our interpretation of all of that information? And what are we going to do about it? Pretty straightforward. Um, so subjective information kind of traditionally is at least in emergency medicine and EMS, it's basically OPQRST. This is I this is basic, right? This is like EMT school week one. You learn this acronym and you learn how to kind of start eliciting this information. But I remember, and I have seen some folks that I used to work with. There's a paramedic named Damien who used to be a preceptor, and I remember him telling me that all I want from anyone is a good OPQRST. If you can get that information, you are most, if not all of the way there, and finding out the subjective information that you need to find out. And he's absolutely right. This is still something that we do on a daily basis in the emergency department and in hospitals across the world. So OPQRST, like lifting a lot of weight here. Onset, provocation, palliation, quality, region, radiation, severity, and time. Not that complicated. You get that information, you have a really good sense of what is happening and kind of the factors around how it's happening. Another really good acronym to include in that is sample. So if you layer OPQRST and sample together, you add in the allergies, the medications, past history, surgeons care about last oral intake, and then the events preceding what was going on, you really have a pretty robust history. And we're not going to talk too much about history taking, but I think if you were able to get a really well-defined story about symptoms started here, progressed in this way, associated with these things in the setting of my other medical history, you'll have a really good sense of what's going on with a patient. The other thing to kind of include in this, in the subjective field, is a review of systems. The review of systems in medicine is a very thorough systemic or system-based coverage of all of the things that could possibly be wrong, trying to poke and prod the person to say, hey, have you been having any lumps or glands or stiffness? Or I'm never, almost never going to ask someone about nipple discharge, but if you're going to do a full review of systems, that's in there, right? We think more about illness scripts and focused review of systems. So as you spend more time in medicine, you get used to certain medical conditions, the signs, symptoms, and features of those different conditions, like the ones that you care about. And then you ask questions around that. So think about cardiac pain. Not only do we ask, are you having chest pain? We ask, is it radiating to your neck? Is it radiating to your shoulder? Did you feel sweaty? Did you feel nauseous? Right? That's a good illness script for cardiac chest pain. And when you are more accustomed with that script and those symptoms, you can ask a focused review of systems around that illness script. So, subjective information, you get your OPQRST, that tells you what's going on right now. Sample provides some framework for that. You find out about what their history is like. And then the directed review of systems really fills in the gaps and makes sure that you're not missing anything that they might not have thought to tell you about. Objective information is kind of the next step in our SOAP mnemonic. It's pretty straightforward. This is your physical exam, and that includes vital signs. I'm not going to harp on this because again, not kind of the nature of this talk, but a physical exam should be at least, we kind of tailor it to every patient, but you should have in your mind a physical exam that you can do from the doorway. If they're just saying that I just want to go to the hospital, take me to the hospital, there's nothing wrong with me, you should be able to say, well, they've got pink, warm, dry skin, patent, self-maintained airway, no increased work of breathing, moving all four extremities, neurologically grossly intact, right? Including some sort of physical exam is important on every single run that we do, and we should have a set of vital signs. Vitals are just really important to everything that we do, and we will always need to account for abnormal vital signs when we're taking care of a patient. Then we've got the assessment and plan. This is the thing that is kind of the most bastardized in emergency medicine relative to the rest of how medicine documents and communicates. Instead of doing a formal system-based problem by problem assessment and plan, in emergency medicine, we think more about our medical decision making, which is really kind of a narrative of the course of care. So we summarize briefly what's going on. We say, I think that this might be I think that this is most likely what's going on. I know that I need to think about these other things, and you create a differential that accounts for those major life-threatening diagnoses. And then you talk about how that care happened over the course of a visit. For EMS, it's roughly the same thing, right? It makes more sense to include a narrative about your call as opposed to a system-based assessment plan. So, in the world of emergency medicine, a presentation around a SOAP format might sound like this. I've got a 21-year-old male patient with altered mental status and a fall. EMS found him on the ground outside of his dorm 15 minutes prior to arrival at the bottom of some steps. He's slurring his speech. He vomited once. No other witnesses. Blood glucose is 98. He's got a laceration with controlled bleeding, neuro intact, C-collar applied. There's our objective information. Patient endorses some headache and nausea, but no complaints, can't recall preceding fall. Drank a lot of beer, no other past medical history allergies. There's a sample. Otherwise, some nice fevers, chills, dyspnea, etc. And then when we're doing our assessment and plan, we talk about what we're going to do about it. We talk about the imaging that we're going to do. We're going to talk about the results of that and kind of what we did about it. I won't go through all of that, but it's pretty brief. It's a lot of information broken down and compressed into a way that is understood readily because of the way in which it falls together, if that makes sense. So, great. Who cares, right? That's not the world that you do. The problem is that if medicine has a common language, why do we lose information in handoff? Why are we always talking about communication breakdowns between EMS and hospital staff when we're bringing patients? It turns out that this is just one of those areas that is most prone to difficulty, not only in our realm of medicine, but kind of across the board. Anytime that we're changing hands with patient care, there's a good potential that information gets lost. And we've started to look at this objectively. Like this study back in 2017 was looking quantitatively at the content of what EMS was presenting on critically ill patients coming to the emergency department. What's interesting, 80% of the time they included a chief concern. Seems like that would be obvious, but it's hard. You show up into the critical care bay, you're under stress. You maybe had a plan, but that easily can go to hell. Half of the time, there were physical exam findings that were pertinent to the patient's presentation. Only half of the time. And then, again, a little more than half the time was there a description of the scene. I'm never going to see that scene. You're the only ones who are going to have any information about the setting in which all of this occurred. And that can be super relevant, not only to the care that we're providing, but then the patient's ultimate disposition, whether we send them back to an unsafe house or not. So we've also looked at how do we do this better, and like what are the problems that EMS providers think is going on. And what they found is that EMS providers felt like everything was really disorganized, that when they're trying to do patient handoffs, they were, had trouble advocating for their patients because hospital staff is so scattered. There's not enough time, there's not enough focus, and there's not enough standardization or respect for the healthcare providers, trying to provide that handoff. And this is super true. Emergency medicine is, the whole healthcare system is a disaster. But if you spend any time in an ER, you know that it's just a land of interruptions. And we've studied this a number of times. Physicians in the emergency department were interrupted on average 12 and a half times an hour, more than any other specialty. And almost all of the time, they did not return to the tasks that they were doing beforehand, which means that if we're trying to listen to you give report and we get interrupted about a nurse, or some concern that's going on, we probably aren't going to come back, right? That's just kind of the nature of the beast. So we know that there's a problem. We know that it's hard to communicate between EMS providers and hospital staff and handoff. And we know that medicine has its own language that it speaks. So what if we tried to kind of bridge this gap? The thing that is most commonly used and most commonly referred to is the MIST tool. I'm sure that most of you have heard of this. MIST stands for Mechanism or Medical Complaint, Injuries or Illness, Signs and Symptoms, and Treatments. So it's kind of SOAP-y, right? We've got kind of mechanism or medical complaint. So this is going to be the information from someone else that we identify, kind of subjective information. Injuries or illnesses identified. This is going to be our objective stuff that we've figured out, along with signs and symptoms, which also falls into that objective category. And then treatment is, our assessment and plan, basically. Pretty matches up pretty well. But when we studied how well this tool works, we found that hospital staff still only retains about 50% of what's being told to them. And when we use MIST as a standardized tool in a trauma center, there wasn't really any value added to the way that the pre-hospital events were understood or subsequently documented by hospital staff. So even when we kind of take the time, come up with a structured tool, there's still a lot of information being missed, and so to speak. We're still dropping the ball to some extent. It can be a really robust tool, though. And particularly in the setting of trauma, the MIST tool works really well. And I've got an example of what that looks like. I apologize in advance for audio working or not working, but we're going to give it a shot.
All right, 3 patients for you. Your most critical patient is this patient here. All patients were part of an IED explosion. The 24-year-old German soldier, IED explosion, bilateral amputations, pelvic fracture, abdomen, chest, heart, good by point of care ultrasound. Retrieved 3 units of RBCs, 3 units of plasma, got arapenem 1 gram, got calcium chloride, got TXA 2 grams, got ketamine 5 milligrams. He's volume depleted, loss of blood. Tourniquets are in place. Do you have any questions for me? No, it's good. All right, 3 patients for you.
It's pretty cool. That guy is damn good at what he does. And I think that that's a really succinct, directed, and concise way to convey information about trauma patients in particular. So MIST works pretty well. We just don't have any evidence that it works really well when we've studied it. Part of the problem is that nursing culture and all of, any nursing specialties are learning a different way to communicate information, and they use SBAR typically. So that's situation, background, assessment, and recommendation. It's just, again, it's not terribly different. The order is roughly the same, but the nuances of how these tools work are different enough that information can kind of be lost. If you're expecting to hear a differential diagnosis, and instead you're hearing more about the scene, later on in the presentation, it just can kind of confuse the listener as to what's really going on and what's most important. So how do we do this really well? Let's take kind of all of this information and figure out how do we create a best practice that we can start using tomorrow to communicate between EMS and hospital staff better. The first thing that I think is important, and I'm sure whenever you transfer a critical patient over, I'm sure that this is happening to some degree, but we should start by setting the stage. So when we come into the room, we should make kind of some comment on stability if that's not asked or elicited. And ask, when do you want to hear from me? Are we going to move the patient over, or am I going to talk before we move the patient over? Because we really only want one thing happening at a time. The idea is that we should be deliberate in our actions, deliberate in our communications, and really not let there be any ambiguity about who's talking, when are we going to talk, and who the audience is, right? I'm sure that we've all done it. I know that I have. We start to move the patient over, start talking about it, get distracted, drop something. It's less smooth. It's going to lead to people, getting distracted and not listening more easily. And we don't want that. Next, I think you should pick a tool. If that's Mist, great. If it's SOAP, if it's SBAR, whatever tool kind of makes the most sense for your brain, I think that that's the one that you should start with and practice using. The biggest thing is being consistent in your actions and knowing, even for yourself, when you're expecting to hear or say certain parts of the story or certain parts of the information. For what it's worth, when I made this talk maybe a year or two ago, I was thinking about it and I was trying to come up with a good acronym for my own. I don't love MIST. I don't love SOAP. I don't love SBAR. So I came up with this idea of DEFT. And this is literally just a tool that I was like, well, if I was going to be doing this every day, this might work well for me. DEFT stands for demos, so demographics, events and eyes, so what happened, what are we seeing, findings, what do we elicit, what's our objective information, and then treatment, what did we do? So with demographics, what I mean by that is doing a robust one-liner. This is like one-liners carry a lot of weight, particularly in emergency medicine. It's the first thing that you hear about a patient, and it sets the stage. You get a framework for what's going on. We'll talk more about that in a second. For events and eyes, this is really that subjective information, that history of present illness, your OPQRST, relevant details of the scene that the hospital is never going to get otherwise. That's going to be completely lost in the wind if you don't provide that information. And then what did you find? What did you elicit on your physical exam? What are the other objective findings along with the vital signs? And then your thoughts and treatment. What do you think is going on? What did you do about it? So what this might look like. For the demographics, this is a 20-year-old male patient with no significant medical history presenting with intoxication and head injury. Patient was found at the bottom of 3 concrete steps in a significant pool of blood after an unwitnessed fall, unknown loss of consciousness. Endorses head pain, but does not recall any events leading up to the injury. On exam, we've got stable vitals with a highest heart rate of 94, lowest blood pressure of 110, and we've got a laceration to the left scalp with bleeding controlled. Glucose is 92, and wound has been bandaged, collar is in place, nasal cannula 2 liters. Any questions or concerns? It's looking easy, about 30 seconds probably. And I think that's kind of a good goal for all of these tools, is that they should be pretty brief, they should be pretty succinct. Let's talk about the one-liner for just a second. I think this is, if you take anything away from this chat, I think figuring out how to do a good one-liner is a really important skill to develop. The idea is that when I meet a patient, I don't know them from Adam. And what I want to know is just the pertinent details about what brings them here, like who they are, what's their deal, what is the framework for the understanding of the rest of what I'm going to hear. And what this should include, I think, ideally, are their age and their sex, their relevant medical history. This might include medications in what their chief complaint is, right? So if we've got 2 patients with chest pain, that's great. It's a good start. But if this is a 7-year-old male patient who got hit in the chest with a baseball, is otherwise completely healthy, and really he's complaining of toe pain, that's a different story than a 75-year-old male patient with hypertension, hyperlipidemia, coronary artery disease, status post bypass 3 years ago on Lasix, Coumadin, and presenting with ripping, tearing chest pain into his back, right? Like, if you tell me that, I know that I'm listening specifically for cardiac complaints. Maybe I did a talk earlier today about aortic complaints, which is, another one of those things like, oh, the way that you've framed this patient, the way that you've framed his complaints, I know that I'm going to be listening for certain information and kind of expect you to lead me down a certain road. If you just talk about, that same guy's like, oh, this is a 57-year-old male professional pickleball player, coming in with chest pain, right? Like, that's not getting me where I need to go. I'm not going to be listening for the right things during the rest of the handoff. The other thing that I think is kind of important to do is to leave some documentation behind. And I think even more than leaving documentation behind, if you have a quick sheet that you can use, it can really structure your ability to obtain and then regurgitate information in a meaningful and organized way. So back when I was in college and just a Colby kid, as the Delta medics like to call me, I came up with this run sheet, this quick sheet on the left. And the idea was I wanted a tool that I could use when we went on a call that would remind me to get the information that's important and then help me to convey the information that's important. I created sections that were, relevant to the most the most prevalent patients that we would see, in terms of just drunk kids. And then the interventions that we were most likely to use. Getting into paramedic school, I kind of tweaked that and tried to come up with what are the illnesses, presentations, interventions that are going to be most relevant, or what are the can't misses. And for us in EMS, that kind of comes down to the time sensitive emergencies like stroke, ACS, STEMI, and really being deliberate about eliciting that specific information, and then being able to convey that to hospital staff, not only in the handoff, but then leaving this note behind so that there's some record of that. So when I created this quick sheet, I made sure that if I had stroke or TIA on my mind, that I was recording a last seen normal, who that was, and how to get in contact with them, along with the pertinent focal neurologic deficits. And that I structured it so you're just circling it or crossing it off. Same thing with the thrombolytic checklist, going through and just saying like, okay, this is information that is going to directly impact timely patient care. And the more deliberate that I can be with it, the more directed my communication is going to be once I get to the hospital. I understand entirely that we're moving into a digital era. We're firmly in a digital era. And so paper tools don't necessarily make the most sense anymore. But I think the thing to consider is, how do you optimize your workflow to record the information you want and then subsequently convey that information in a timely manner to the hospital, so that the patient can get the best care possible. And when our kind of governing bodies, so the National Association of EMS Physicians, has looked at this and put out a position statement about how should we transfer care between EMS providers and receiving facilities, documentation is a major part of it. They say leave documentation and leave critical information behind. They also said, in so many words, don't be a dink. Like be professional in your interactions and, on both ends. Obviously, it's not just one side or the other. And it's still really hard. They kind of acknowledge the fact that we don't have a single robust tool that really works well for every single person in every single situation. So that kind of means that we have to figure out what works best for us, what works best for our situation. So in terms of takeaways, set yourself up for success. Figure out what kind of a tool is going to make your job easier, is going to help hospital staff hear the information in the most organized way possible, and then use that to get yourself set, know what you're going to say, and be ready to leave something behind. I know a lot of times we're just like uploading the PCR before leaving, and that's great. But even if it's just like if you're coming down here to main med and kind of sketched out your presentation on the back of the 12-liter, the back of the vital signs, and you just leave those pertinents in the room, that can go a long way. And that can make a big difference in the patient care. We've got all kinds of references, and so it's definitely on the shorter side. So we've got plenty of time to take questions if you guys have any. Or just silence.
Well, it looks like you were fairly popular though. So, Jack, could you talk to the group about how your process actually ties into quality assurance? That you're what you went through and how it can enhance quality improvement work.
In terms of like the communication or the documentation, or
Yeah, the communication and the documentation are kind of tied together in that way, and
yeah.
they do a similar thing.
So I think you can almost work backwards, right? If you think about what needs to be communicated to the receiving providers, if you answer that question, you're going to know what information you need to elicit. And if you have a tool or a mechanism for capturing that information, then you're going to be able to do that consistently every time. And the information that we're trying to get through that process is the stuff that is important, that contributes to the nature of those time sensitive emergencies like stroke, getting the information that's on that thrombolytic checklist. And these are the sorts of things that we have national standards around, that we measure at a national level and kind of figure out like, okay, this is a high performing system because they have captured this amount of information, which means that they can push TPA within a certain window. And then that just contributes to the systemic care of that patient, and really ensures good care for all stroke patients kind of coming behind them, for example. And then I think in terms of just more routine communication, quality assurance, like being able to have a record and have a sense of what actually happened to a patient on an individual basis is just really important. Like I don't the main med process can be kind of convoluted where you hit triage 5 and then you get directed to a room and then you drop that patient off. As the provider, I may never talk to you. I might never get to ask you like, hey, where did you find this person? I might not know how to take care of them best if I don't get that certain information about what you saw, what you did. And that can make a really big difference in the safety of our patients. I don't know if that's if I'm reading your mind right, Eric, or not, but
No, you hit on some of the topics. We did have a request for your quick sheet.
oh, would love to.
Would love to. If you have it, I can email it out to the group.
Yeah. It's
for
like
that.
a janky PDF that I made in Google Docs slides or PowerPoint or something like that. I'm really not a very good graphic designer, I've learned.
You
but I
can't be
think
good at everything.
or anything for that matter. But I think if you, yeah, I'm happy to send it out and then consider like what makes sense for your agency, your situation. And you can just make something in PowerPoint like that.
Well, everyone, we appreciate your time today. If there are no further questions, you have an evaluation in the chat that you can complete. We also have our webinar for Friday is also included. Dr. Bohansky will be talking about ballistic trauma. And if there are no more questions, we appreciate all of you. Happy EMS week. We're really excited about that. And we'll see you all very, very soon. Thank you, Jack.
You're welcome. Thanks, everyone.